Awesome.
I'm Dr. Allison. I'm a psychiatrist. This lecture is on antidepressants. Today we will learn about the various classes of antidepressants, including their mechanism of action, how they are used clinically, and potential side effects. We will conclude the lecture by discussing medications used in the treatment of bipolar disorder. We will first start with a brief overview. Depression afflicts about 14 million adults every year in the United States. The lifetime prevalence rate in the U.S. is 16%. That equals 21% of women and 13% of men. This equals 32 million people. The symptoms of depression can be easily remembered with the mnemonic SIG-E caps. S stands for sleep, I, interest, G is guilt, E, energy, C, concentration, A, appetite, P, psychomotor agitation or depression, and the second S is suicidal thoughts. Mania is the opposite behavior, and a mnemonic to remember it would be dig fast. D is distractibility or easy frustration. I is irresponsibility or erratic, uninhibited behavior. G is grandiosity. F, flight of ideas. A is activity decrease with weight loss and an increased libido. S, sleep is decrease, and T is talkativeness. There are two major theories of the pathophysiology of depression, and they include the monoamine hypothesis and the neurotropic hypothesis. First, let's talk about the monoamine hypothesis. This states that there is a deficiency in cortical and limbic serotonin, norepinephrine, and dopamine. This hypothesis believes that this is central to understanding the proposed mechanisms of action of the antidepressant medications that are currently on the market. The neurotrophic hypothesis is next. Stress and pain can cause a drop in brain-derived neurotrophic factor, also called BDNF. This drop in BDNF is going to lead to less neuroplasticity, less resilience, and less neurogenesis. It's hypothesized that this leads to atropic structural changes in areas of the brain responsible for memory, learning, and emotion. These areas of atrophy are observed on imaging studies in depressed patients. This hypothesis believes that effective antidepressant therapies will increase neurogenesis and synaptic connectivity. Now let's talk about the mechanism of action of antidepressant drugs. Most clinically useful antidepressant drugs are going to potentiate, either directly or indirectly, the actions of norepinephrine and or serotonin in the brain. This led to the biogenic amine theory, which proposes that depression is due to a deficiency of these monoamines, such as norepinephrine and serotonin, at certain key sites in the brain. Conversely, this theory states that mania is caused by an overproduction of these same neurotransmitters. One problem with the amine theory is that it's oversimplistic. It fails to explain why the pharmacological effects of these antidepressant and anti-mania drugs do not occur immediately. In fact, it takes several weeks to see a therapeutic response. The potency of antidepressant drugs in blocking neurotransmitter uptake often does not correlate with clinically observed antidepressant effects, suggesting that decreased reuptake of neurotransmitter is only an initial effect, which may or may not be directly responsible for its antidepressant actions. The addition of an antidepressant leads to the gradual downregulation of inhibitory receptors. This leads to a greater release of neurotransmitter into the synaptic cleft, leading to postsynaptic activity and a therapeutic response. Now let's specifically talk about selective serotonin reuptake inhibitors. This is a group of chemically diverse antidepressant drugs that specifically inhibit serotonin reuptake. You can contrast this group with the tricyclic antidepressants that non-selectively inhibit norepinephrine and serotonin. The common side effects associated with tricyclics, such as orthostatic hypotension, sedation, dry mouth, and blurred vision, are not commonly seen with SSRIs because of their selectivity for the serotonin receptor. SSRIs are relatively safe in overdose. And because of this, they have largely replaced tricyclic antidepressants and monoamine oxidase inhibitors as the drug of choice in treating depression. SSRIs include fluoxetine, which is the prototypic drug, citalopram, escitalopram, fluvoxamine, paroxetine, and sertraline. Let's talk about the actions of SSRIs. Again, they block the reuptake of serotonin, leading to increased concentrations of this neurotransmitter in the synaptic cleft. And this leads to a graded postsynaptic neuronal response. Antidepressants, including SSRIs, may take at least 2 weeks to produce a significant improvement in mood. Maximum benefit may require up to 12 weeks of treatment. None of the antidepressants are uniformly effective, and what may work in one patient may not necessarily work in another patient. About 40% of depressed patients treated with adequate doses for 4 to 8 weeks do not respond to the antidepressant agent. Patients that do not respond to one antidepressant may respond to another, and about 80% or more will respond to at least one antidepressant drug. It is important to note that you need to maximize the dosage before moving to a new antidepressant, unless there were significant side effects or an allergy present. These medications do not usually produce central nervous system stimulation or mood elevation in normal individuals. Let's talk a little bit about the therapeutic uses. The primary indication of SSRIs is depression, for which they are effective as the tricyclic antidepressants. Other psychiatric disorders also favorably respond to SSRIs, including obsessive compulsive disorder, panic disorder, generalized anxiety disorder, post-traumatic stress disorder, social anxiety disorder, premenstrual dysphoric disorder, and bulimia nervosa. We should note that fluvoxamine is the only SSRI that has an approved indication for obsessive compulsive disorder, and only fluoxetine is approved for bulimia nervosa. Let's look at the pharmacokinetics. All SSRIs are well absorbed after oral administration. Their peak levels are seen in about 2 to 8 hours on average. Sertraline has a half-life that's 1.5 times higher in women. It undergoes significant first-pass metabolism, and food increases its absorption. It undergoes fecal excretion as well. Sertraline is FDA approved for depression, social phobia, PTSD, PMDD, OCD, and panic disorder. Fluoxetine differs from the other members of the class in 2 respects. Number 1, it has a much longer half-life, about 50 hours, and is available as a sustained release preparation allowing once-weekly dosing. The metabolite of the S enantiomer, S-norfluoxetine, is as potent as the parent compound. The half-life of the metabolite is quite long. It averages about 10 days. Fluoxetine and paroxetine are potent inhibitors of hepatic cytochrome P450 isoenzyme 2D6. And this is responsible for the elimination of tricyclic antidepressants, neuroleptic drugs, and some antiarrhythmic and beta-adrenergic antagonist drugs. 7% of the Caucasian population lack this P450 enzyme and therefore metabolize fluoxetine and other substrates of this enzyme very slowly. They are referred to as poor metabolizers. Excretion of SSRIs is primarily through the kidneys, except for paroxetine and sertraline, which undergoes fecal excretion. Dosages of all these drugs should be adjusted downward in patients with hepatic impairment. Let's look at some adverse effects. The adverse effects of SSRIs are fewer and less severe than with TCAs and MAOIs. Headache, sweating, anxiety and agitation, nausea, vomiting, diarrhea, sexual dysfunction, changes in weight, insomnia and somnolence, and there are also a potential of drug-drug interactions with SSRIs. Let's look at sleep disturbances. Paroxetine and fluvoxamine are more sedating than activating, so they may be useful in patients who are having difficulty sleeping. Conversely, patients who are fatigued and complaining of excessive somnolence may benefit from one of the more activating medications, such as fluoxetine or sertraline. Sexual dysfunction can be a side effect of SSRIs. Patients can complain of loss of libido, delayed ejaculation, and anorgasmia. These are often underreported side effects, mainly because patients are too embarrassed to tell their physician, and physicians often don't ask their patients about them. One option for managing SSRI-induced sexual dysfunction is to replace the offending antidepressant with one with fewer side effects, such as bupropion or mirtazapine. Alternatively, the dose of the medication can be reduced. In men with erectile dysfunction and depression, treating the sexual dysfunction directly may improve their function while keeping the patient on their antidepressant. Treatment-emergent mania is also a concern. This is the emergence of a manic or hypomanic episode in a bipolar individual after starting an antidepressant. So this happens when a patient is started on an antidepressant and they start to have the symptoms of dig fast that we discussed earlier. The phenomenon is not fully understood. Clinicians are advised to screen their patients of signs and symptoms of bipolar disorder before starting antidepressants. Some sources state that it takes an average of 10 years before a bipolar patient is accurately diagnosed as such. They mostly have the diagnosis of depression and are constantly treated with antidepressants and undergo this treatment-emergent mania. Antidepressants can also be used with children and teenagers. They should be used cautiously because about 1 out of 50 children become more suicidal as a result of SSRI treatment. This phenomenon is thought to be related to treatment-emergent mania in undiagnosed juvenile bipolar patients. Pediatric patients should be observed for worsening depression and suicidal thoughts whenever an antidepressant is started or its dose is adjusted. Suicide attempts are unfortunately common in depressed patients. One must keep this in mind when writing medications and giving refills, since the most common method is overdose. Large intakes of SSRIs usually do not cause cardiac arrhythmias compared to the arrhythmias of tricyclic antidepressants, but seizures are a possibility because all antidepressants may lower the seizure threshold. All SSRIs have the potential to cause a serotonin syndrome that may include symptoms of hyperthermia, muscle rigidity, sweating, and chronic muscle twitching. So it's important to inform your patients of these risks, especially when combining antidepressants. One must be very careful when transitioning a patient from an SSRI to an MAOI. Patients may complain of changes in mental status and vital signs. This can occur when you have this switch, especially when you're switching from an MAOI and you have another highly serotonergic drug on board. So extended periods of washout are needed when you're switching from one class to the next. Let's talk a little bit about discontinuation syndrome. Whereas all the SSRIs have the potential for causing a discontinuation syndrome when they're abruptly stopped, the agent with the shorter half-lives and having inactive metabolites have a higher risk of such an adverse reaction. Which SSRI do you think has the lowest risk of discontinuation syndrome? You're correct. Fluoxetine has the lowest risk of causing an SSRI discontinuation syndrome because of its long half-life and the long half-life of its active metabolite. Possible signs and symptoms of such a serotonin-related discontinuation syndrome include headache, malaise and flu-like symptoms, agitation and irritability, nervousness, and changes in sleep patterns. In clinical practice, I've noticed that paroxetine can have a significant discontinuation syndrome when compared to the other SSRIs due to its short half-life. Neonatal abstinence syndrome is also a concern. This happens when neonates are exposed to antidepressant medications during gestation, especially in the 3rd trimester. They are increased risk of developing symptoms such as irritability, agitation and tremors, increased respiratory rate and nasal congestion, and emesis and diarrhea. These manifestations are usually self-limiting and disappear by age 2 weeks. Symptoms are more commonly reported with fluoxetine and paroxetine exposure. Before we move to the next section of antidepressants, let's look at each of the SSRIs individually and look at their pharmacokinetics and how they're used clinically. First is citalopram. It has minimal drug interaction potential, so this medication is a better choice for elderly or patients with comorbid problems. Citalopram is approved for depression, but it's also used off-label for alcohol-induced mood disorders, panic disorders, premenstrual dysphoric disorder, social phobia, and trichotillomania. Next is escitalopram. This is the S enantiomer of citalopram. Of the SSRIs currently on the market, this has the highest affinity for the human serotonin transporter, also called SERT. It is FDA approved for major depressive disorder, generalized anxiety disorder, social anxiety disorder, and panic disorder. Fluoxetine has a much longer half-life than the other SSRIs. It's about 50 hours. It's available as a sustained preparation, allowing once-weekly dosing, and it also has an active metabolite, which has a half-life of about 10 days. Fluoxetine is FDA approved for major depressive disorder, obsessive compulsive disorder, bulimia nervosa, and panic disorder. It is also used in treatment-resistant depression when combined with an atypical antipsychotic olanzapine. Fluvoxamine has the shortest half-life of all the SSRIs. It works on serotonin as well as an alpha-1 receptor, and it has the highest affinity at this alpha-1 receptor than any of the other SSRIs, and it may contribute to its anxiolytic properties. Fluvoxamine has less sexual side effects when compared to the other SSRIs. Fluvoxamine is FDA approved for obsessive compulsive disorder. Its extended release form is also used in social anxiety disorder. Paroxetine has the highest incidence and severity of discontinuation syndrome because of its short half-life. It's a potent inhibitor of cytochrome P450 just like fluoxetine. It undergoes fecal excretion as well as renal. It's FDA approved for depression, OCD, PTSD, generalized anxiety disorder, and panic disorder. As a special note, this is the first antidepressant formally approved in the United States for the treatment of panic attacks. Sertraline's half-life is 1.5 times greater in women. It undergoes significant first-pass metabolism, food increases its absorption, and it undergoes fecal excretion just like paroxetine.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together, we'll go through the quick review in the study guide. Hi, I'm Dr. Chris Lewis. It's time for your quick review number 1. Let's get started. Why is it important to screen patients for bipolar disorder prior to starting an antidepressant? Well, if the patient has bipolar disorder, the antidepressant may cause emergent mania. So a patient comes in who doesn't know they have bipolar disorder, they're just depressed because one of the major symptoms of bipolar disorder is a depressed state. So you start them on an SSRI and all of a sudden they feel great, maybe a little too great because now they're mowing the lawn 7 times, painting the house, and spending a lot of money. So you can diagnose bipolar in someone by giving them an antidepressant and causing this emergent mania. Next, what warning about SSRIs must you give parents when starting their child on an SSRI? So this is a very controversial subject about pediatric patients and SSRI. So what's the problem? Well, there's an increase in suicidal ideation in children with major depressive disorder who take SSRIs. So there's lots of controversy about, well, is it really the medication that's causing the suicidal thoughts, or are these just very depressed patients, and now that we're giving them antidepressants, they have enough energy now in order to commit suicide? But there have been some pretty nice studies that do show that there seems to be an increased risk from the antidepressant. So you have to be very, very careful. So we screen our patients very well. I like to get all of my psychiatric, pediatric patients into child psychiatrists. I think that's really where they need to be for close observation. So you tell parents look for any changes in mood in your children, look for any major personality changes, any reclusive behavior, all that type of stuff. So you don't want to willy-nilly put all pediatric patients who have some depression on SSRIs without really talking with those parents and keeping close tabs on them. Which SSRI has the highest incidence of discontinuation syndrome? So patients have been on an SSRI for a while, they stop abruptly and they start feeling terrible. They can get nausea, vomiting, they get agitated. Some can even complain of flu-like symptoms. It's not a pleasant situation. And the one that causes it the most is paroxetine, and that was one of the earlier SSRIs. A lot of patients on paroxetine, and you do have to warn them even before starting paroxetine, hey, don't miss medications. Even if you miss this for a couple of days, you might start feeling poorly. And then when you want to stop patients on these medications, you want to titrate them slowly. Next, which SSRI has the greatest efficacy when treating major depressive disorder? So which one of these works the best? Well, trick question, none of them. They all work about the same. They have very equal and similar efficacies. Sometimes when I'm talking with patients, I try to tell them, well, not every SSRI or SNRI, whatever we're going to use, will be the right one for you, but I can't tell you all the time which one is the right one for you, because they all work pretty similarly and they all have great efficacies, but it's hard to know. Next, what is serotonin syndrome? Well, this is interesting because we call this a syndrome, but it's really just an overdose phenomenon. This isn't something that some people have different reactions to serotonin than others. It's actually you're getting too much serotonin. So some people will refer to this as serotonin toxicity or serotonin poisoning. But you're still going to see this on tests and probably in school as serotonin syndrome. So it's an overdose of serotonin in the CNS, but also in the peripheral serotonin receptors. So it'll result in tachycardia, shivering, sweating, dilated pupils, myoclonus, hyperreflexia. You can get fever, and pretty high fevers at that, 104, sometimes even higher, and hypertension. Rarely you can get shock. I mean, people can die from serotonin syndrome, so this is not the same thing as a minor withdrawal symptom where you're not kind of feeling good and you're agitated. This can actually lead to significant morbidity and even mortality. So next question, how do you manage serotonin syndrome? Well, the first thing is stop all drugs that increase serotonin. So you want to stop your SSRIs, you want to stop your SNRIs, your MAOIs, stop your TCAs, stop everything. Sometimes if you're having a significant enough syndrome or toxicity, you can start cyproheptadine. And this is a serotonin antagonist, so it's going to actually help remove some of that serotonin and decrease your symptoms overall. And then supportive care. So if you're getting close to that really, really severe shock type situation, then you want to remember your ABCs. You want to protect your airway and your breathing and your circulation. So you're not going to see this very often, but you might have to intubate someone. You might have to put an IV in them. You have to keep them stable. Next. Why are citalopram and escitalopram potentially good medications for the elderly or patients with other medical problems? Well, these are great medications because they have very few drug-drug interactions. So our elderly patients, our other patients with major medical problems, they're going to be on other drugs. And these two are nice because they're not going to interact with those other drugs very often. Next. A 25-year-old female patient with depression and anxiety complains that her fluoxetine is helping her depression, but it's not helping her anxiety. She feels like she's on edge all the time. What other SSRIs might be helpful for her? Well, fluoxetine is a bit of a stimulating SSRI, so it helps kind of elevate the mood, give you a little bit more energy. Not always the greatest thing for your anxious or patients who have insomnia. So you might want to use one of the depressing type, I know it's a terrible way of saying it, but one of the SSRIs that sort of brings down your energy level a little bit. So we use paroxetine and fluvoxamine a little more often for those anxious depressed patients because it decreases that energy level, brings them off edge just a little bit. How long does it take for an SSRI or an SNRI to show improvement in depression? Well, this is really, really important when you're counseling your patients. You're not going to give them a pill and they're going to feel better in 3 days. I always explain to my patients this is a long haul. This is something that you're going to have to take continuously for a while in order to build up the levels into the body, to change your mood slowly. So I tell people at a minimum 2 weeks. Most of the time, I don't even tell them 2 weeks. I'll tell them 3 to 4 weeks. So what I tell my patients is that here's the medication. Call me for any problems if your mood's getting worse or if you're having a side effect. But I want you to come back and see me in 3 weeks, and don't expect to have any improvement in that time period. So I warn them ahead of time, like, just don't expect this to work. And then when we get to 3 weeks, we'll reevaluate, decide if we need to change dosages or stay where we're at. But really tell people not to get frustrated with that lack of clinical improvement in that short amount of time. All right, well, that's going to conclude our quick review number 1. Let's get back to your main lecturer.
Next, we will switch gears and talk about serotonin norepinephrine reuptake inhibitors. They may be effective in treating depression in patients in whom SSRIs are ineffective. Depression is often accompanied by chronic painful symptoms such as backaches and muscle aches, which SSRIs are also relatively ineffective. This pain is part modulated by serotonin and norepinephrine pathways in the CNS. Both SNRIs and tricyclic antidepressants, with their dual action in both inhibiting the reuptake of serotonin and norepinephrine, are sometimes effective in relieving physical symptoms such as neuropathic pain, such as diabetic peripheral neuropathy. SNRIs, unlike your tricyclics, have little activity at adrenergic, muscarinic, and histamine receptors, and have fewer of these receptor-mediated side effects. SNRIs may precipitate a discontinuation syndrome if they are abruptly stopped. If this happens, patients will report symptoms of dizziness, headache, irritability, anxiety, fatigue, diarrhea, abnormal dreams, hyperhidrosis, and paresthesias. Many former users of SNRIs who experience discontinuation syndrome describe it as intolerable. The discontinuation syndrome may be mitigated or prevented by tapering the drug down slowly or by using a long-acting SSRI such as fluoxetine. Venlafaxine is one example of an SNRI. It's a potent inhibitor of serotonin reuptake and at medium to higher doses an inhibitor of norepinephrine reuptake. It's a mild inhibitor of dopamine reuptake at higher doses. It has minimal inhibition of cytochrome P450 isoenzymes, but it is a substrate at 2D6. The half-life of the parent compound plus its active metabolite is around 11 hours. Only 27% of the compound is bound to plasma proteins, so it's not expected to be involved in protein displacement interactions. Common side effects of venlafaxine include nausea, headache, sexual dysfunction, dizziness, insomnia, sedation, and constipation. At high doses, there may be an increase in blood pressure, especially the diastolic blood pressure and heart rate. Desvenlafaxine is a newer medication that has hit the market. It's the active metabolite of venlafaxine. It is marketed as the first non-hormonal treatment for the symptoms of menopause, and it has a similar side effect profile to venlafaxine. Duloxetine is also an SNRI. It also inhibits serotonin and norepinephrine reuptake at all doses. It is extensively metabolized in the liver to numerous metabolites. Because of this, it should not be administered to patients who have hepatic insufficiency. This is also going to include your chronic alcoholics for similar reasons. The metabolites are excreted in the urine, and the use of duloxetine is not recommended with patients with end-stage renal disease. Food is going to delay the absorption of this medication. The half-life is about 12 hours. It's highly bound to plasma proteins. Gastrointestinal side effects of duloxetine include nausea, dry mouth, constipation or diarrhea, and vomiting are less seen. Insomnia, dizziness, and somnolence with sweating are also seen. Sexual dysfunction also occurs with the possibility for an increase in either blood pressure or heart rate. Duloxetine is used for depression, generalized anxiety disorder, peripheral neuropathy, and fibromyalgia. Next, we will start to talk about atypical antidepressants. This is a mixed group of agents that have several different action sites, but they're not any more or less efficacious than your tricyclic antidepressants or SSRIs, and their side effect profiles are different. We will start by talking about bupropion. Bupropion acts as a weak dopamine and norepinephrine reuptake inhibitor. It has a short half-life, and because of this, it may require more than once-a-day dosing or the administration of an extended release formulation. Bupropion is unique in that it assists in decreasing the craving and attenuating the withdrawal symptoms for nicotine and tobacco users who are trying to quit smoking. It is marketed under the trade name Zyban for this use. Possible side effects of bupropion include dry mouth, sweating, nervousness, tremor, a low incidence of sexual dysfunction. Because of this, we use this in clinical practice for patients who have had sexual side effects with SSRIs or SNRIs. Bupropion also has an increased risk for seizures at high doses, so it's important to ask a seizure history of your patient. Bupropion is metabolized by cytochrome P450-2D6 and is considered to have a relatively low risk for drug-drug interactions. In clinic, we use bupropion for depression, smoking cessation, and it's also used off-label for ADHD. Mirtazapine also falls under the categories of atypical antidepressants. Mirtazapine is going to enhance serotonin and norepinephrine neurotransmission by blocking alpha-2 receptors. Some of its antidepressant activity is due to blocking serotonin receptors and blocking its reuptake. Mirtazapine is a sedative because it is a potent antihistaminergic drug, but does not cause antimuscarinic side effects like the tricyclics do, or interfere with sexual functioning like SSRIs do. Common side effects of mirtazapine include increased appetite and weight gain. So this is the perfect medication to use for a depressed patient who is complaining of a decreased appetite and weight loss. Mirtazapine is markedly sedating, which is a good thing for patients who are having difficulty sleeping. So mirtazapine is primarily used for depression, but has also been used for anxiety spectrum disorders as well. Next, we will talk about nifazodone and trazodone. They are weak inhibitors of serotonin reuptake. Therapeutic benefit appears to be related to their ability to block postsynaptic 5-HT2A receptors. With chronic use, these agents may desensitize 5-HT1A presynaptic autoreceptors and thereby increase serotonin release. Both of these agents are sedating, probably because of their potent histamine blocking activity. So often they are used for patients with depressive symptoms that have insomnia. Trazodone has been associated with causing priapism, and nifazodone has been associated with the risk of hepatotoxicity. Next, we will talk about tricyclic antidepressants. Tricyclics work by blocking the reuptake of serotonin and norepinephrine. Their mechanism of action is similar to venlafaxine and duloxetine, but they differ because of their side effect profile. In this class of medication include your tertiary amines, which include imipramine, amitriptyline, clomipramine, doxepin, and trimipramine. You also have the secondary amines in this class, which include disipramine, nortriptyline, and protriptyline. Meprotilene and atomoxetine are related tetracyclic antidepressants that are also commonly included with this class of medications. They all have similar therapeutic efficacy, and the drug of choice may depend on such issues as patient tolerance to side effects, prior response, pre-existing medical conditions, and duration of action. Patients who do not respond to one TCA may benefit from another medication in the same group. These drugs are a valuable alternative for patients who did not respond to SRIs or SNRIs. Let's talk about their mechanism of action. TCAs and atomoxetine are potent inhibitors of the neuronal reuptake of norepinephrine and serotonin. At therapeutic concentrations, they do not block dopamine transporters. By blocking these major routes of neurotransmitter removal, the TCAs cause increased concentrations of these monoamines in the synaptic cleft, ultimately resulting in antidepressant effects. Meprotilene and desipramine are selective inhibitors of norepinephrine reuptake. TCAs also block serotonergic, alpha-adrenergic, histaminic, and muscarinic receptors. By blocking these receptors, they have multiple side effects. TCAs elevate mood, they improve mental alertness, increase physical activity, and reduce morbid preoccupation in 50 to 70% of individuals with major depression. The onset of the mood elevation is slow, requiring 2 or more weeks. They do not commonly produce CNS stimulation or mood elevation in normal individuals. Let's look at some therapeutic uses. TCAs are effective in treating moderate to severe major depression. Some patients with panic disorder also respond to TCAs. Imipramine has been used to control bedwetting in children older than 6 years of age. But it should be used cautiously because it can cause cardiac arrhythmias and other serious cardiovascular effects. The TCAs, primarily amitriptyline, have been used to treat migraine headache and chronic pain syndromes, for example, neuropathic pain. Let's talk a little bit about the pharmacokinetics. Tricyclic antidepressants are well absorbed upon oral administration. Because of their lipophilic nature, they are widely distributed and rarely penetrate into the CNS. This lipid solubility also causes these drugs to have variable half-lives. For example, imipramine can have a half-life to 4 to 17 hours. As a result of their variable first-pass metabolism in the liver, TCAs have low and inconsistent bioavailability. Response and plasma levels can be used to adjust the dosage. Initial treatment period is typically 4 to 8 weeks. The doses can be gradually reduced to improve tolerability unless relapse occurs. These drugs are metabolized by the hepatic microsomal system, and thus they may be sensitive to agents that induce or inhibit cytochrome P450 isoenzymes. Let's look at the adverse effects of tricyclics. The blockade of the muscarinic receptors can lead to a constellation of symptoms which may include blurred vision, dry mouth, urinary retention, constipation, and aggravation of narrow angle glaucoma. It can also lead to slow cardiac conduction, similar to quinidine, which may precipitate life-threatening arrhythmias should an overdose of these medications be taken. They block alpha-adrenergic receptors that can cause orthostatic hypotension, dizziness, and reflex tachycardia. It should be noted that in clinical practice, tachycardia is the most common problem in the elderly. Imipramine is the most likely, and nortriptyline the less likely to cause orthostatic hypotension. Sedation may be prominent, especially in the first several weeks of treatment, and is usually related to these drugs' effect on the histamine or H1 receptor. Weight gain is also a common side effect of TCAs. Precautions. TCAs, like all antidepressants, should be used in caution in known bipolar patients, even during their depressed state, because antidepressants may cause a switch to manic behavior. TCAs also have a very narrow therapeutic index, so a 5 to 6-fold increase in the maximum daily dose can be lethal. Because of this, depressed patients who are suicidal should only be given limited quantities of these drugs, and they should be monitored closely. TCAs may exacerbate certain medical conditions such as unstable angina, benign prostatic hyperplasia, epilepsy, and patients with pre-existing arrhythmias. Now let's look at some of the pharmacokinetics and uses for tricyclic antidepressants. First up is amitriptyline. Its primary use is for depression, but amitriptyline has also been used to treat migraine headache and chronic pain syndromes like neuropathic pain. Amoxapine is a strong norepinephrine reuptake inhibitor and a weak serotonin inhibitor. It also possesses actions at other sites that may lead to side effects. One of its metabolites has dopamine blocking effects, and so common side effects could include neuroleptic malignant syndrome and tardive dyskinesia. Amoxapine is used in depression, anxiety, and panic disorders. Amoxapine is contraindicated in children because it lowers the seizure threshold to the extent that fits may be precipitated, especially in children. Clomipramine is a potent serotonin reuptake inhibitor. Its active metabolite is a potent norepinephrine reuptake inhibitor. Clomipramine is primarily used in obsessive compulsive disorder, but it can also be used in depression, panic disorder, narcolepsy, and premature ejaculation. Imipramine is an anticholinergic medication, so you need to be cautious with this medication in elderly because this action can lead to increased confusion and delirium. Imipramine is primarily used for depression and enuresis in kids. Nortriptyline is the active metabolite of amitriptyline. It inhibits the reuptake of serotonin, norepinephrine, and to a lesser extent is a strong histamine blocker, which leads to sedation. It's primarily used in depression, but can also be used in anxiety and insomnia. Protriptyline decreases the reuptake of norepinephrine and serotonin as well. It is unique in that it is energizing instead of sedating. For this purpose, it is used in narcolepsy, sleep apnea, and chronic pain. Trimipramine is a moderate serotonin and norepinephrine reuptake inhibitor. It also has strong histamine blocking properties, which can cause sedation.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together, we'll go through the quick review in the study guide.
And now, here's Dean with the weather.
Thanks, Jim. Hello for News 12. I'm here to give you your daily weather forecast.
It's time again to play Name That Drug. What drug is associated with the following side effects? Dry mouth, tinnitus, blurred vision, mania. Time's up! The drug is amitriptyline. These side effects are mostly due to amitriptyline's anticholinergic activity. Thanks for playing. See you next time on Name That Drug!
All right, it's time for our quick review number 2. Let's get started. What's the major contraindications for duloxetine? Remember, this is our SNRI, good for a lot of different things. Well, you don't want to use this with patients with hepatic insufficiency, so liver problems, and chronic alcohol use, so also going along with your chronic liver problems. Next, which antidepressant can be used to help patients quit smoking? Well, that's going to be your bupropion. Nice medication. It's interesting that they actually have different formulations of this. It's the same medication, same dosages, but they have one that's marketed for an antidepressant and one that's just marketed for quitting smoking. And kind of depending on how you write it as a prescription will determine whether or not an insurance will cover it too. So it's interesting. It's nice when you have depressed patients that need to quit smoking because then you can use that for both problems. Next. A 38-year-old male with major depressive disorder is taking paroxetine. He has good control over his depression, but he's having decreased libido and erectile dysfunction. How would you manage this patient? So this is something that will come up over and over and over again. SSRIs and sexual dysfunction. And it's interesting how you'll go through this with patients. They really like the way that they're feeling. They're not depressed. They want to have more sexual activity, but now they can't have sexual activity, so it's a form of frustration that's pretty much intolerable. It's not that patients prefer their sexual activity more than their mood, but they really it's one of those things where you have to fix both problems in order for people to be really satisfied. So what are you going to do? Well, first we need to talk about paroxetine. So it's one of the shorter half-lives. You can have that discontinuation syndrome that we talked about earlier. So first you want to titrate off the paroxetine very, very slowly. So you're going to decrease this over the span of weeks, and hopefully they're not going to have any symptoms of that. So what medications are we going to try to use that have lower incidences of sexual dysfunction? Well, we talked about them in this section. Bupropion is one of them, and that was sort of the original one that we used a lot for our patients with problems with sexual function. But you can also use desvenlafaxine and mirtazapine. Both of those have pretty good antidepressant effects and lower sexual side effects compared to the other medications. A 42-year-old female with major depressive disorder has had suicidal ideation in the past and is currently feeling like her depression is uncontrolled. Which class of antidepressants should you avoid? Well, so this is important. We have a patient here who might be at high risk for another suicide attempt. Not that we said that she had one in the past, but she's had suicidal ideation. So we want to take that very seriously. So which medications are going to get us in bigger trouble? Well, the TCAs, the tricyclics, it's much easier to get to a lethal dose of the TCAs than some of the other antidepressants. SSRIs, SNRIs, you can still have some serious morbidity with overdoses with that, but you're going to get much more lethal doses at lower dosages with the TCAs. So be careful with TCAs with your unstable, possibly suicidal patients. What causes the sedation, dry mouth, blurry vision, urinary retention, and constipation seen in the TCAs? So the TCAs work really well. They work just as well as our SSRIs or SNRIs, so why don't we use them very often? Well, because they have a lot of side effects that people don't tolerate. They really complain of that dry mouth. They wake up in the morning, they feel terrible. They get a lot of constipation, the things we just mentioned. So why does this happen? Well, TCAs will affect the histamine receptors and your muscarinic receptors, so you're getting a lot of anticholinergic effects, and it's exactly what we have here: sedation, dry mouth, blurry vision, urinary retention, and constipation. So that's the big drawback of the TCAs. What are the major treatments for nocturnal enuresis? So we talked about one tricyclic antidepressant that we use, imipramine, that we use for nocturnal enuresis. And then there's another one called desmopressin, DDAVP. So this medication can be used, and it really does work. It'll decrease that nocturnal enuresis. But here's the drawback of both of those medications. Once you stop them, that nocturnal enuresis in children will come right back. So it's just a temporary fix for kids. So what's the one thing that's really been shown to help are the enuresis alarms. So these are alarms that go into the underwear, and as soon as a little bit of urine hits the sensor, this ear-piercing alarm goes off, and it wakes up the child, and then they run to the bathroom and try to empty their bladder without having a major accident. And it's been really the one thing that has shown long-term effectiveness in nocturnal enuresis. It's horrible to live with. I've had to go through this in my household as well, and it's I mean, the end of the world is coming. This alarm is super, super loud, and it wakes you up, and it's startling and all that type of thing. So it's a pain, but it actually does work. And the imipramine, the desmopressin, are just sort of temporarily improving the situation. Good for maybe if you're going to camp or if you're going over to spend the night at someone's house. Those medications can be very helpful just to decrease embarrassment, but not great for long-term control. A patient with major depressive disorder and insomnia might benefit from which medications? Well, so we want our sedating antidepressants in this situation. Trazodone is a great one. Nifazodone is another one. You can use the TCAs because they're sedating as well. Remember that we just talked about that histamine effect. But trazodone, maybe not quite as many side effects along with nifazodone than the TCAs. Next. An elderly patient with depression also is having problems with maintaining weight due to decreased appetite and energy. What antidepressant would be appropriate? So this is a common scenario. You have someone who's getting older and older, they're depressed, they're not motivated to get up and make themselves something to eat. So a great medication is mirtazapine because it increases appetite and it increases the mood. So you can kind of kill two birds with one stone here by improving that mood and giving them a little bit more of an appetite so they'll be more prompted to get up and eat. A 30-year-old female has major depressive disorder and recurring body aches. What SNRI antidepressant would you want to try on this patient? So we have a lot of patients with fibromyalgia or chronic pain syndromes, and these people can be depressed about it. I mean, if you're having to deal with pain every day, it can certainly affect your mood. So one medication that's been shown to improve both chronic pain and depression is duloxetine. So great medication to try on your fibromyalgia patients. All right, that's going to conclude our quick review number 2. Let's get back to your main lecturer.
Let's next learn about monoamine oxidase inhibitors. Monoamine oxidase is a mitochondrial enzyme found in nerve and other tissues, like your gut and your liver. In the neuron, MAO functions as a safety valve, so it's going to oxidatively deaminate and inactivate any excess neurotransmitter that may leak out of the synaptic vesicles and when the neuron is at rest. MAOIs may irreversibly or reversibly inactivate the enzyme, permitting neurotransmitter molecules to escape degradation. Therefore, they accumulate within the presynaptic neuron and leak into the synaptic space. It's believed to cause activation of norepinephrine and serotonin receptors, and it may be responsible for indirect antidepressant action. Let's look at the mechanism of action of MAOIs. Most MAOIs, such as phenolzine, form stable complexes with enzyme MAO, causing irreversible inactivation. This is going to result in increased stores of norepinephrine, serotonin, and dopamine within the neuron, and subsequent diffusion of this excess neurotransmitter into the synaptic cleft. One problem is that it not only inhibits the MAO in the brain, but also in the liver and the gut, that catalyze the oxidative deamination of drugs and potentially toxic substances such as tyramine, which is found in certain foods. Because of this, MAOIs have a high incidence of drug-drug and drug-food interactions. Because of the possibility of drug-drug and drug-food interactions, they are usually reserved as last-line agents. Let's talk about their pharmacokinetics. MAOIs are well absorbed after oral administration, but the antidepressant effects require at least 2 to 4 weeks of treatment. Enzyme regeneration, when irreversibly activated, varies, but it usually occurs several weeks after the termination of the drug. When switching antidepressant agents, a minimum of 2 weeks delay must be allowed after MAOI therapy has been terminated and the initiation of another antidepressant class started. Adverse effects of MAOIs. Severe and often unpredictable side effects are due to the drug-food and drug-drug interactions, and this limits the widespread use of MAOIs. For example, tyramine, which is contained in certain foods such as aged cheese and meats, chicken liver, pickled smoked fish, such as anchovies or herring, and red wines, is normally inactivated by MAO, and the individual receiving an MAOI are unable to break down the tyramine contained in these foods from the diet. Tyramine causes the release of large amounts of stored catecholamines from nerve terminals, and they result in occipital headache, stiff neck, tachycardia, nausea, hypertension, cardiac arrhythmias, seizures, and possibly stroke. Patients must therefore be educated to avoid tyramine-containing foods. Phentolamine or prazosin are helpful in the management of tyramine-induced hypertension. Treatment with MAOIs may be dangerous in severely depressed patients with suicidal tendencies. They may purposefully consume tyramine-containing foods. Other possible side effects of treatment with MAOIs include drowsiness, orthostatic hypotension, blurred vision, dry mouth, dysuria, and constipation. Again, MAOIs and SSRIs should not be co-administered due to the risk of life-threatening serotonin syndrome. Both types of drugs require a washout period of at least 2 weeks before the other type is administered, with the exception of fluoxetine, which should be discontinued for at least 6 weeks before an MAOI is started. The combination of MAOIs and bupropion may produce seizures. Phenolzine is a non-selective and irreversible MAOI. It's going to inhibit both isoforms of MAO, which include MAO-A and MAO-B. This leads to the prevention of neurotransmitter breakdown, so they are readily available in the synaptic cleft. Phenelzine is FDA approved for major depressive disorder, but it has also been used for treatment-resistant major depressive disorder, treatment-resistant panic disorder, and social anxiety disorder. Sedulene, in normal doses, it is a selective irreversible MAO-B inhibitor, but at larger doses also inhibits MAO-A. Sedulene is administered as a transdermal patch, which may produce less inhibition of hepatic MAO at low doses because it avoids first-pass metabolism. It has a low oral bioavailability and is increased when it's ingested with a high-fat meal. Its bioavailability is also drastically increased in women who are on oral contraceptives. The last medication in this group is transcyclamine. It is also a non-selective and irreversible inhibitor of both isoforms of MAO. It's FDA approved for major depressive disorder without melancholic features, but it's also used in treatment-resistant major depressive disorder, panic disorder, social anxiety disorder, and PTSD. Last, we will talk about the treatment of mania and bipolar disorder. The treatment of bipolar disorder has recently increased, partly due to the increased recognition of the disorder and also due to the increased number of medications the FDA has approved. One of the classic medications used for bipolar disorder is lithium. Lithium salts are used prophylactically for treating manic depressive patients and in the treatment of manic episodes, and therefore is considered a mood stabilizer. Lithium is effective in treating 60 to 80% of patients exhibiting mania and hypomania. Although many cellular processes are altered by treatment with lithium salts, the mode of action is unknown. Lithium is given orally, and the ion is excreted by the kidney. Because of this, lithium salts can be toxic. It has a very narrow therapeutic index. Common side effects may include headache, dry mouth, polydipsia, polyuria, polyphagia. You can also have GI distress. That's why you can either give lithium with food, or you can give a sustained release formulation to reduce the GI irritation. Other side effects include a fine hand tremor, dizziness, dermatologic reactions, fatigue, and sedation. Adverse effects due to higher plasma levels may include ataxia, slurred speech, a coarse tremor, confusion, and convulsions. One possible side effect of high doses of lithium could be diabetes insipidus. Thyroid function may be decreased in patients that are taking lithium, and lithium-induced hypothyroidism can be treated with levothyroxine. So it's important once you start a patient on lithium that you need to check thyroid as well as kidney function on a regular basis. There are other drugs that we use in clinical practice to treat bipolar disorder. These include mood stabilizers and antipsychotics. There are several anti-epileptic drugs, including carbamazepine, valproic acid, and lamotrigine, that have been identified by the FDA as mood stabilizers. Each of these three medications have been FDA approved for acute and mixed manic episodes. Lamotrigine specifically has been FDA approved for the maintenance of bipolar depression. The older and newer antipsychotic agents may improve manic symptoms include risperidone, olanzapine, ziprasidone, aripiprazole, and quetiapine have also received FDA approval for the treatment of mania. Benzodiazepines are also frequently used as adjunctive treatments for the acute stabilization of patients with mania. They're also helpful because bipolar patients often complain of severe anxiety. Since these medications take an average of 2 to 4 weeks to start working, benzodiazepines have been very useful in calming the anxiety and agitation portion of bipolar disorder.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide. All right, we're back for our quick review number 3. Let's get started. Using high doses of lithium can be associated with diabetes insipidus. If this occurs, what is the pharmacologic approach to treating the lithium-induced diabetes insipidus? So this is a little bit of a tricky question, and we'll talk about it again in another question later on, but amiloride, a potassium-sparing diuretic, is used. Now, what else do we use for diabetes insipidus? Well, we use desmopressin. But we don't use it in this situation because desmopressin will work for central diabetes insipidus. Now, in this case with lithium, we see a nephrogenic diabetes insipidus. Next, what is the danger of combining an MAOI inhibitor with an SSRI? So, we don't see MAOIs very often, but you will get this question somewhere where you're combining an SSRI or some other serotonin reuptake inhibitor or something that increases serotonin with an MAOI. So what's the whole scenario? Let's review the whole MAOI problem. So you'll get serotonin syndrome is basically the answer to the question, but let's expand upon that a bit. So MAOI is a class of the antidepressant drugs that it's almost never used. Now, they're considered last resort meds for major depressive disorder. And historically, they were used before the SSRIs were created, especially when patients weren't able to take the TCAs or tricyclic antidepressants. So what do? So MAOIs will prevent the breakdown of monoamine neurotransmitters. So what are those? So that includes serotonin, melatonin, epinephrine, norepinephrine, dopamine, and tyramine. So you can easily get a buildup of these neurotransmitters on an MAOI. So this can result in many side effects. So if you have too much epinephrine and norepinephrine, then you're going to get hypertension. So that's sort of what happens here. You just kind of get an overall buildup of these neurotransmitters. So what's more interesting about MAOI is that foods containing tyramine can also elicit a lot of these responses because it helps kind of all of these neurotransmitters that are built up can be released all at once when you get a large tyramine dosage. So that tyramine is found, unfortunately, in a lot of food. So you'll see it in aged cheeses, you'll see it in alcohol. So patients who are on MAOIs have to really watch what they're eating or they're going to get hypertensive crises or other problems that can be really worrisome. So when you're combining that MAOI with an SSRI, you're getting way too much serotonin. And we talked about in our previous quick review what happens when you get too much serotonin. You get a lot of those symptoms like tachycardia and agitation and sweating and fever and all that great stuff. Next, when should an MAOI be used clinically? Well, I just mentioned this, almost never. I don't think I've ever seen a patient on an MAOI. Now, it can be used as a last resort for major depressive disorder when all other treatments have failed. So they can't take SSRIs, they can't take SNRIs, they can't take TCAs, they're not taking some of the atypical antidepressants, they're not taking some of the antipsychotics at low dosages. So this is really, I would say, reserve this for your psychiatrists. Let them take care of MAOIs because there's just a lot of problems that go along with them. How does eating aged cheese while taking an MAOI cause hypertension? So, as we just mentioned before, MAOIs cause a general increase in neurotransmitters like serotonin, norepinephrine, and dopamine. Aged cheeses contain tyramine, and tyramine causes release of stored neurotransmitters. So that norepinephrine can then increase blood pressure. Next, a 32-year-old bipolar patient presents with a stiff neck and a feeling of restlessness. What class of medication is he probably taking and how should you treat this side effect? So the lecture doesn't go into great detail about these classes of medications, but this is referring to a neuroleptic or an antipsychotic. So a lot of these medications are used for chronic control of bipolar disorder. And what is this patient having? Well, he's having extrapyramidal side effects. So this includes tremors, restlessness, stiff muscles, and it can be really dramatic. So what do we use to help counteract some of this? Well, we're thinking that some of these antipsychotic medications, the reason behind the extrapyramidal side effects is that you're having sort of an upregulation of cholinergic activity in the brain. So what do we use to help counteract that? Anticholinergic medication. So you can use benztropine, which is a commonly used medication in combination with our antipsychotics, or you can even use over-the-counter diphenhydramine or Benadryl, and that can help counteract these symptoms. Next, What is the mechanism of action of the atypical antipsychotics? So we just talked about how sometimes they can cause side effects, but in order to help better control our bipolar symptoms, then we can use the atypical antipsychotics. So they block dopamine receptors and they block the serotonin 5-HT2A and 5-HT1A receptors. What is the potentially permanent side effect of the antipsychotics? So this is tardive dyskinesia. So you can get oral, facial, lingual dyskinesia. You'll get patients who have kind of a protruding tongue or a smacking of lips, or they'll do a chewing motion. They'll kind of moving their mouth around, that sort of thing. It looks really unusual. It can be very disconcerting for patients if they have these problems. But you can get even limb problems, limb stiffness. You can get torticollis, which is when patients kind of get stuck in a real stiff neck position. Their muscles get really, really hard. Now, this is thought to be due to that increased cholinergic activity that we talked about before. So we try to use our anticholinergic medications, but the nice thing about the atypical antipsychotics is that we see a lot lower incidence of this tardive dyskinesia than we did with our older typical antipsychotics. All right, that's going to conclude our quick review number 3. Now is a good time to pause the video and complete the in-session quiz. Then restart the video and we'll go through the quiz together.
Which antidepressant can curb cravings for nicotine and is sometimes used to help patients quit smoking? Well, what's the problem? Do you know it or not? Today! The answer is bupropion. Look, if you can't handle a little pressure, you're not cut out for this. Why don't you just drop out and go to veterinary school? On second thought, you don't even have what it takes to be a vet.
All right, we've made it to the end of our lecture. It's time for your end of session quiz. Let's get started. Match the drug to its major side effect. First one is amitriptyline, where you can get xerostomia, orthostatic hypotension, and reflex tachycardia. Selegiline, for that one you're going to get occipital headaches, cardiac arrhythmias, and most importantly, food-drug interactions. Lithium, that's going to be associated with diabetes insipidus, tremor, and GI upset. And then venlafaxine, you can get sexual dysfunction, nausea, and sedation. Match the following clinical descriptions of depressed patients with the most appropriate therapeutic agent. So we've got a list of our antidepressants here, and we're going to try to match them up with the type of patient that we see. 43-year-old, extremely anxious woman who has failed on TCAs, SSRIs, and SNRIs. Well, this is going to be our last resort medication, phenelzine. 67-year-old, underweight widower with insomnia. Think of mirtazapine. 24-year-old woman complaining of chronic muscle aches. Duloxetine. 32-year-old man tapering off antidepressants to avoid withdrawal. Fluoxetine. 50-year-old man attempting to quit smoking. Bupropion. 43-year-old man with depression and insomnia who has failed TCAs. Trazodone. A 27-year-old male has a compulsion to wash his hands multiple times a day. He has the need for everything in his life to be very organized to the point where his behavior interrupts his daily tasks. What SSRI or what TCA would be appropriate for him? Well, for FDA approval, fluvoxamine has been FDA approved for obsessive compulsive, and clomipramine is also used for obsessive compulsive disorder. Next, explain neonatal abstinence syndrome. So this is a very interesting phenomenon. So neonatal abstinence syndrome occurs in some neonates born to women taking SSRIs. So symptoms include agitation, tremors, you can get increased respiratory rate, nasal congestion, emesis, and diarrhea. So symptoms are more commonly reported with fluoxetine and paroxetine exposure. So when you're screening your mothers in labor, you still need to pay attention to their antidepressants. Babies can come out, and these are nonspecific symptoms, so increased respiratory rate. What are we going to think about in babies with increased respiratory rate? Well, you're going to think of things like pneumonia, neonatal sepsis. So really serious things can be going on, and they can be put on antibiotics and go through a lot of testing and come to find out it's really due to this SSRI phenomenon. Match the following drug with its mechanism of action. So the first thing we have here is sertraline. So it selectively inhibits serotonin reuptake. Duloxetine selectively inhibits serotonin and norepinephrine reuptake. Bupropion will block dopamine and norepinephrine reuptake. Amitriptyline will block reuptake of serotonin and norepinephrine, and the way it's different is it also blocks muscarinic and histamine receptors. And then trazodone will block postsynaptic 5-HT2A receptors, and it will overall increase serotonin release. Next, in what medication used to treat bipolar disorder would you want to check kidney function and thyroid function on a regular basis? Well, that's going to be lithium. Next, a 23-year-old male patient currently undergoing treatment for bipolar disorder presents with new onset nocturia. What medication is he probably taking, and explain why he has nocturia? Well, this patient is on lithium, and the lithium is causing nephrogenic diabetes insipidus. So let's talk just real briefly about diabetes insipidus. So diabetes insipidus is where ADH, or antidiuretic hormone, is not effective in concentrating the urine. So you're letting out dilute urine, and you're getting polyuria as a result of that. Now, don't be fooled, because there's two types of diabetes insipidus. There's a central version that happens in the brain, and then there's this nephrogenic version that's basically the ADH just is not as effective as it usually is. So in this case, we have nephrogenic, so there's enough ADH in the body, the kidneys just aren't responding to it. So that's why you get the polyuria, and usually the presenting symptom is someone's like, well, gosh, I'm having to wake up in the middle of the night to pee. So be on the lookout for that for lithium. It's still a relatively uncommon side effect for lithium, but be aware of it. What is serotonin syndrome, and how do you manage it? So we've talked about this already before. So serotonin syndrome, remember, it's not really so much a syndrome as an overdose situation. It's a toxicity or a poisoning of too much serotonin in the body. So it's affecting not just the CNS, but it's also affecting the peripheral serotonin receptors. So the things you get: tachycardia, shivering, sweating, dilated pupils, myoclonus, hyperreflexia, fever, hypertension, and even shock. So what do? Stop all the drugs that increase serotonin, so you're stopping your SSRIs, your SNRIs, your MAOI, and then you can use cyproheptadine, which is a serotonin antagonist, and then always remember supportive care. If someone looks like they're in trouble, you want to support all of their major functions, ABCs, all that type of stuff. What food should patients taking MAOIs avoid? So those are your tyramine-containing foods. So think of aged cheeses, think of alcohol. So anything that has tyramine in it, you got to avoid. Next, what is discontinuation syndrome? What SSRI is more likely to have this problem, and how do you avoid it? Well, remember, discontinuation syndrome is basically just withdrawal symptoms, and it's from the abrupt cessation of taking an SSRI. And this can occur in some of these, even if you miss 1 or 2 pills or 1 or 2 days. So symptoms include headache, malaise, agitation, flu-like symptoms. People just don't feel very good. Traditionally, paroxetine is the most likely to cause the discontinuation syndrome. And why is that? Because it has a short half-life, so it's quick to get in, but it's also quick to get out. So how do you avoid it? You want to taper the dose down slowly. So you can do this over the span of weeks. Now, what you can also do is that you can put them on a very long-acting SSRI like fluoxetine. So it's not uncommon to have someone on paroxetine, they want to get off of it. Well, let's just put you on fluoxetine for a month or so, get the paroxetine out of your system, but still have enough action of the SSRI to where you're not having that discontinuation syndrome. And then you can stop the fluoxetine faster than you ever would with the paroxetine. All right, so that's going to conclude our lecture today. I hope you learned a little something, and good luck studying.